Good afternoon, everyone. I am Mary Holt, and welcome to the 22nd show in the Sounds from Our Community series. If you are listening for the first time, hello and welcome. As my regular listeners will know, We're All in This Together from High School Musical is the theme song for this show, and it is very appropriate today for this special show on COVID-19 and vaccines. I was delighted to help Gary, an eminent consultant in infectious diseases who lives locally. In his personal capacity, he wanted to answer questions that listeners have sent in about COVID and vaccines, so that he could help us to make informed decisions and in turn enable us to educate our friends and families and the wider community. So in effect, creating a communication virus. As you will hear, the vaccination programme is our way out of lockdowns, hopefully for good, but for it to succeed, we all really do need to be all in it together. We are going to be low on musical notes today, but I hope high in information notes. A quick explanation of the show. It is pre-recorded. A few weeks ago, I asked for questions and I received over 100. I then grouped them into themes and asked Gary the questions via Zoom on Monday afternoon. He has answered every question. As always, lots of the questions are being asked by the people themselves, and for the others, you will hear my voice. So, let's get started. Good afternoon, Gary. Thank you very much for doing this very special show. I thought we would start with why you wanted to do this show.
Well, I'm a doctor in infectious diseases working for the NHS, although I'll add that I'm attending here in a personal capacity. And I think that the NHS and the government in general have been rather slow in giving out information around vaccination. And I realise that there is a lot of misinformation and disinformation out there about vaccination and about COVID in general. And so this is the fourth session I've done online, the previous three being to professionals. And I've tried to pass on as much information as I possibly can about vaccination and try to break some of the myths about vaccination. So, and I thought that Potter's Bar Radio, having previously worked with you on the programme for Potter's Bar Choral Society, would be a good medium. And although I recognise that quite a lot of people listening to this may be older, may have already had the vaccination, I can reassure them, but also help them to answer questions from their younger friends and family as well.
So, shall we start right back at the beginning? And what is a vaccine?
A vaccine is a substance that you either inject or swallow or even spray up someone's nose, which stimulates an immune response. An immune response is where the body produces antibodies or white cells, which are very specific for an infectious disease or an infectious agent. And the whole point about vaccines is that they are mild infections in essence, which you give to that person so that they only react in a very mild and minimal way. But most importantly, their immune system develops a memory for that infection, so that when they come across the real infection, the more aggressive infection, their immune system is already primed to react to it and therefore prevent serious infection. So this perhaps goes right back to the first vaccine in this country, which was, everyone I'm sure will remember, by Edward Jenner in the late 18th century, where he noticed that milkmaids were not catching this very serious disease called smallpox. And he realized that it was because that these milkmaids were catching a mild disease called cowpox from milking the cows. And so he conducted an experiment where he infected a child, a 9-year-old child as it happened, with cowpox. And then he subsequently challenged that child with a mild dose of smallpox and find that the child was completely immune to the smallpox. And it's gone on from there. Over the years, vaccination has got more and more widespread, has got more and more effective, and the technology, of course, has really come into the 20th century with the COVID vaccination.
What is COVID-19?
COVID-19 is a disease caused by a coronavirus. Technically, it's called SARS-CoV-2, but it's a coronavirus which is similar to the coronaviruses that called winter sniffles and coughs and colds, but actually is much closer to the more serious types of coronavirus that cause SARS and MERS, which are two infections that you find in the Middle East and Far East. And when exposed to this infection, most people get fever, cough, loss of smell and taste, but you can get a wide variety of other symptoms as well, such as gastroenteritis, liver disease. One of my own colleagues just had hepatitis and nothing else due to coronavirus, due to COVID, that is. And so it can cause a range of diseases. But the two killer points, so to speak, are that it has a significant mortality. So in the UK, overall mortality has been round about 1%, perhaps a little bit less now that we've got some, currently now that we have some better treatments such as dexamethasone. And your chance of death increases not only with age, but according to other factors as well. So your chance of death really starts to climb after the age of about 50. Yeah, COVID-19 has a much higher mortality rate than seasonal flu. It's somewhere between 3 and 10 times more likely to kill you than seasonal flu. So in an average flu season, approximately 1 in 1,000 people die of influenza. As I said earlier, currently about 1 in 100 people infected with COVID-19 are dying. I'll give a secret away. I'm 67, and so I have about a 3% chance of dying if I get COVID. And this goes on up to people in their 80s and 90s, where the chance of dying, depending on whether they're in a nursing home or not, maybe 10 to 20%. So it has a very serious, mortality rises with age. So if you are in your 80s and 90s, your chances of dying are between 10 and 20%, particularly people living in nursing homes. So very much a disease to be avoided. But even young people are not out of the woods as far as this infection is concerned. On the one hand, the acute infection can be quite miserable and upsetting. My own daughter had it not too long ago, and she was quite unwell for several weeks with fever and coughing and being generally unwell. But the other big issue for young people is this problem called long COVID. Long COVID affects 10 to 20% of people who have COVID-19 of all ages, but including young people. And as a result of this, you do not fully recover from the acute infection. You continue to feel tired, you have difficulty concentrating, you may continue to lose weight, you may have problems breathing, and this can go on for many, many months. So long COVID, it can be quite debilitating. There are many stories out there of people who have had long COVID going for 6 months or more, and it has had a major impact on their life. So people who are under the age of, say, 40, who think that COVID-19 is a trivial infection, and if they catch it, they'll be all right, they're not actually correct in thinking that, because they do have a chance of being unwell for many, many months afterwards, and a significant chance of having that problem.
So I think your slide said something like 20% it could be. Was it up as far as that? It could
yes,
be.
Yes, it depends how you define long COVID and what groups you look at, but it's somewhere between 10 and 20% have long COVID, depending on whether you're just describing symptoms, which particular organisation looked at it. So the Office for National Statistics have done one survey, and the Zoe COVID-19 tracker have also done a study looking at the effects of long COVID, and so come up with slightly different figures, but it's in the range 10 to 20%.
And the other thing from your slide was some of these people were asymptomatic. So it was only when they tested, they found that they had COVID. They weren't particularly ill.
So about 30% of people who catch SARS-CoV-2 don't have any symptoms, but that doesn't necessarily protect them from A, getting reinfected, and B, developing subsequently long COVID. So there are people who have presented with long COVID as their first symptom of having SARS-CoV-2 infection. So young people out there, or people with young people in their friends and family, please get the message out there that COVID is not a trivial infection, even in young people.
Why should people have a vaccine?
The reasons why people should have vaccination are first and most obvious: to prevent illness. And I've already talked about mortality and long COVID. But the other thing to remember is that we've got a new strain of SARS-CoV-2 in the UK now. Some people call it the English strain or the Kent strain. And that is about 70% more infectious than the original strain. So that has put us in this latest lockdown. And that has caused infection to spread much more widely. There is also a possibility that the new strain causes worse symptoms as well, although that's still not absolutely clear. So particularly for the people who have been offered the vaccine, and we're offering it in a tiered approach with the people most at risk, the very elderly and healthcare workers first, and people in nursing homes first, you need to take this vaccine as soon as you can, because otherwise you are at significant risk of dying if you catch the infection. For the younger people, please take this vaccination when offered, because you will help prevent the spread of the infection, and I can talk a little bit about that as well. But more importantly, you can protect yourself from both getting unwell with the acute infection, but also protect yourself from developing long COVID.
Would it be useful next to talk about the various vaccines that are on offer and how they work and how they've been tested?
Yeah, so there are at the moment 3 vaccines that are licensed for use in the UK. 2 are messenger RNA vaccines, one made by a company called Moderna, the other by Pfizer in partnership with BioNTech from Germany. And then the other vaccine that's licensed is the AstraZeneca Oxford vaccine, which is what we call a vector vaccine. These vaccines work in very similar ways, actually. So for the messenger RNA vaccines, the messenger RNA is the message that our cells use to make protein. So they've built a messenger RNA to make the spike protein from the coronavirus causing COVID. The spike protein is the important bit of the coronavirus, which helps it latch onto cells to infect people. And so you inject messenger RNA wrapped up in a little fatty package into someone's arm that is taken into the cell, and then your cells make spike protein from that messenger RNA. The messenger RNA then is immediately broken down, so there's no risk of it damaging your cells in, for instance, causing cancer or mutations in any way like that. The spike protein is then carried to the surface of the cells, which then stimulates the immune system to recognize spike protein as foreign. It then produces white cells and antibodies against those spike proteins. And then more importantly, in many ways, you develop what we call an immunological memory, so that your body remembers that it has seen spike protein before. So when your body is then exposed to the real thing, the SARS-CoV-2 virus, you already have immune memory for that spike protein, so your body immediately produces antibodies if there are not already antibodies against it in your blood already, and you produce white cells as well, which help battle against infection. So it prevents you getting seriously ill. The AstraZeneca vaccine is, well, it's not too dissimilar. So the AstraZeneca vaccine uses a chimpanzee adenovirus, which has been genetically altered so that it cannot reproduce. And they've taken 20% of the DNA from the vector, from the adenovirus, and replaced it again with the genetic material that gives the message for spike protein. That adenovirus, which we call a non-replicating adenovirus, is injected into the person's arm. It goes into the cell. The DNA that codes for spike protein is released, and then messenger RNA copies are made of that inside the cell. So you then end up with the same situation that you had with the mRNA vaccines, where you have mRNA which code for spike protein. Spike protein is then displayed on the cell surface, and just like the mRNA vaccines, you stimulate an immune response, which then helps you fight off the real infection when you're exposed. So there are two other vaccines that are just completed phase 3 studies and therefore will be licensed very soon. We have the Novavax vaccine, which is a different type of vaccine altogether. This is what we call a more traditional vaccine. It's made in the same way, for instance, that you make hepatitis A and B vaccines, where you, through tissue culture, insert genetic material that tells the tissue culture to produce spike protein. You then get a broth containing spike protein. You then separate the spike protein off, purify it, and then inject the pure spike protein into someone's arm so that they then develop an immune response. And then we have the so-called Janssen or Johnson & Johnson vaccine, which is pretty well identical to the Oxford AstraZeneca vaccine. They hope that the Janssen vaccine can work with one injection rather than two, but I think that's early days to say whether that's actually really going to pan out or not.
It's another one,
so Moderna is identical to the Pfizer BioNTech vaccine, so it is also an mRNA vaccine. So some people have expressed concern about the rapidity of which these vaccines have been produced, but I can reassure people that corners haven't been cut. It's just that because of the seriousness of the situation, what people have done is take huge financial and logistic risks in producing these vaccines by, instead of doing things in a stepwise way, they've done things in parallel. So normally when you're producing a vaccine, you produce the concept, and then you go into phase 1 trials, which make sure that the vaccine is safe. Then phase 2, which shows you that it produces an immune response. And then phase 3, where you immunize a large number of people who have been exposed to the actual infection and see how well it works in real life. So they've overlapped phase 1, 2, and 3 in a safe way, but overlapped them to very much truncate that process. And at the same time, they took a big financial gamble in scaling up production of these vaccines even before they knew that they worked. So that what usually takes a couple of years, several years, has been all truncated down into about 9 months because people were willing to take a risk. People have not cut corners. The MHRA, the American authorities around the world, the European Medicine Agency have all agreed that all the correct steps have been done and have licensed these vaccines as being safe. There is only one small rider, I would say, and it is small, and I say, almost to dismiss that, is that we have only been vaccinating people for about 9 months now, so we don't have any data going beyond 9 months, but it is pretty well inconceivable that long-term side effects will suddenly appear after we've vaccinated millions of people now, without any problems, that any huge problems will appear in the future.
How has the government prioritised the rollout?
The government have got 9 priority groups, and so what they've done is they've looked at who are the people who are most likely to die, and so they've clearly, the older you are, the more likely you are to die now. But at the very top of that tree is health and social care workers, and the reason they've decided to vaccinate that group is that they're the very people who are being exposed to SARS-CoV-2 virus on a very regular basis. People in ITU, people on wards looking after COVID patients. And then coming down, it's people getting younger in 5-year blocks, and people who are very susceptible to the problems of COVID, such as people who have very serious underlying diseases such as cancer and immunosuppressive disease. So that is the approach that has been made for rolling out the vaccination. And again, it's one that I endorse.
Our next section is what happens at a vaccination.
At a vaccination centre, perhaps I'll go back one step, you will receive an invitation to go for a vaccination, and that will come usually by letter, but it could come by text or email as well. So don't ring up your GP to ask when it's going to happen. You are on a list, the nation is on a list, and you will receive the call. When you attend the vaccination centre, someone will ask you to fill in a consent form and fill in some other information, which includes ideally you having your NHS number. If you've got it, that generally speeds the process up. And then very quickly you will be taken to a vaccinator. A vaccinator may be a doctor, a nurse, a dentist, or someone else who has been trained in vaccination. They will explain to you the side effects of the vaccination and confirm that you're willing to go ahead, and then give you the injection into the deltoid muscle, which is the muscle at the top of your arm where it meets the shoulder. The 2 vaccines currently being offered are very small volume vaccines. The Pfizer vaccine is 0.3 ml. And the AstraZeneca vaccine is 0.5 ml, which is quite a small volume, so that once you feel a little jab as the needle goes into your arm, you generally don't feel the vaccine itself as it's injected into your arm because it's such a small volume. As a general rule of thumb, the injection lasts between 3 and 5 seconds, and then the vaccinator will put a little sticky plaster on your arm, just in case there's a tiny little blood, but usually there isn't, in fact. Then what happens next depends on your vaccine. Because some people receiving the Pfizer vaccine have had a severe allergic reaction called anaphylaxis, then people are asked to wait for 15 minutes before leaving the vaccination centre. Although we now know how to avoid anaphylaxis. So anaphylaxis is extremely rare nowadays, and we know exactly who the people are who are going to get anaphylaxis, so we don't inject them. For the Oxford AstraZeneca vaccine, there have been no reported cases of anaphylaxis. And so once you've had your injection, and providing you don't feel dizzy or faint or feel unwell in any other way, you can go straight back to your car or go back home, whichever transport you came. And then you don't need to book a follow-up appointment, because the follow-up appointment will again be given to you 3 months later by the same means by which you got the first appointment.
Hello, this is Linda. My mother-in-law, Frida, who is 94 and lives in Potters Bar, had her first vaccination on the 16th of January. She was quite excited and a little apprehensive to have this, but has had no side effects whatsoever. And as her family, we're all really pleased to know that this has been done. I would like to ask 3 questions, please. The first, how long the vaccine lasts for. The second, if the medics think the vaccine might be an annual thing, like the flu jab. And my final question, can the vaccine be easily adapted to any new strains of the virus in the same way as the flu vaccine? So could I just finish by adding a huge thank you to everyone in the NHS and all those people, staff and volunteers, who've been instrumental in getting the vaccination programme up and running. Just amazing. Thank you.
We don't know how long the protection from vaccines work. The initial data from the Oxford AstraZeneca study suggested that it lasts at least 5 months, but there is every reason to believe that it's going to last a great deal longer than that. It's just that we don't have the data, but I suspect that it will last at least a year. Then I also suspect that we will be into the realm of everybody getting an annual booster in the same way that we get an annual flu jab. That is my prediction, but it is a prediction only. I could be wrong. It could turn out that the protection is much longer and therefore we don't have to give boosters quite so frequently, or it is just possible that that protection is shorter, but I don't think that's going to happen. We already have some data on the South African variant of the virus, which shows that the current vaccines are slightly less effective. So the Novavax vaccine, I think 25 to 30%, it was 25 to 30% less effective in people infected with the South African variant. There was similar data from the Johnson & Johnson vaccine. So definitely that variant does is not prevented so easily with vaccination, but it is prevented, and in both cases more than 50% of cases were prevented, and in both vaccines hospitalization and death was prevented. So it's just that they're not slightly less effective at reducing symptomatic infection. The so-called Kent or English variant, the evidence is that the vaccines are still working pretty well. There might be a small reduction, but we're only talking in terms of maybe a 10% reduction in prevention of symptomatic disease. But again, the protection against hospitalization and death is still there. We really don't have any data on the Brazilian variant at the moment, although several of the trials were done in Brazil, but I think they were done at a time when we had the initial pandemic variant, whereas this new variant, which is originated from the city of Manaus and spread out, I don't think they've got enough information to say whether the vaccine works or not. But that perhaps leads me on to how we deal with it if we get variants which don't respond to the current vaccine. And the answer to that is that the technology that we're using to make the vaccines allows the vaccine to be changed very quickly. So the mRNA vaccine and the vector vaccines contain a piece of mRNA in or DNA in the vector vaccine. The sequence of that can be changed to cover any new variant, and therefore within a matter of months a new vaccine covering the new variants can be produced. So even if the South African variant or the Brazilian variant comes into this country, the vaccines can be tweaked fairly easily to produce a vaccine which will be effective against them.
Hello, my name's Catherine. I have 3 questions. The first, do you think it would make sense to vaccinate teachers as a priority so we can get schools open ASAP?
The Labour Party in the last week or so have been fighting hard for teachers to get vaccinated. And the response to that is that, first of all, teachers as a group do not have a rate of infection any higher than other people in their own age range. But obviously, if they're older or have medical conditions, they're going to be vaccinated anyway. If you offer the vaccination to the teachers, then with about, I think there's about 500,000 teachers in the UK of various sorts and lecturers, that means that you're going to delay, albeit by a relatively short amount, vaccination of the people who are at higher risk of death from this infection. I can understand why people are worried and concerned, particularly teachers, because they are told that they may have to go back to work on at the beginning of March, but their younger age makes them less at risk of death, and clearly they've got to continue to do the other things that prevent them getting infected: hands, face, space, which I'm sure you're all aware of. So the other argument about vaccinating teachers is that somehow this would make it a safer space, but I'm not sure it would, because for two reasons. First of all, particularly in secondary school children are at risk of catching SARS-CoV-2, albeit at a higher rate of asymptomatic infection. Primary school children do catch it, but at a much lower rate, it seems. But although the vaccination prevents you from dying and largely protects you from getting ill, it probably doesn't terribly effectively prevent spread of infection. And so giving you vaccination doesn't stop you then doing the hands, face, space bit, and will not prevent outbreaks in classes, because the children, particularly in secondary school, are quite likely to spread it as well. So I can see arguments on both sides, but currently the government has not decided to vaccinate teachers or other groups as a priority.
The second, at the minute, children under 16 aren't getting the vaccine. Is this because there isn't enough research on that age group, or is it just because they get mild symptoms?
So the clinical trials only included adults, and that was, again, a pragmatic approach. In fact, mostly younger adults. Only roughly 10 to 20% of people were over the age of 65, although we know that there's every reason to believe that this vaccine works very well in over 65s. There are clinical trials already starting on children. So we will have that information in the fullness of time when those trials have finished. But you're also right in as much as the younger you are, the less likely you are to catch the infection. And younger children are naturally immune. And if you can call it immune, naturally resistant perhaps is a better way of putting it. And technically, this is the coronavirus that causes COVID has this spike protein which attaches to your cell surface, and it attaches to the surface of your cells through a protein called ACE2, which is a protein that's used in the control of your blood pressure, which you can look up if you really want to. So the younger you are, the fewer ACE2 receptor proteins you have in your cells. And that is probably the reason why children are far less likely to catch infection, because the older you are, the more ACE2 receptors your cells have. But children certainly can catch infection, and there is this very rare syndrome which has been seen in very young children, but only a handful. And these children were all children suffering from other severe illnesses at the same time, such as cancer and immune problems. So there is a syndrome which is rather like a previously known syndrome called Kawasaki disease, which has been seen in young children. But you're right, mostly children particularly primary school children, either don't get it, and if they do get it, they get it asymptomatically. The older you are in secondary school children, the more likely you are to both catch it and have symptoms as a result of the infection.
Finally, how will our schools ever get back to normal until children have been vaccinated?
The short answer is I don't know, but I think that what feeds into this is the general adult population being vaccinated widely enough that we're into the realms of people no longer dying, which is the first point, which is we're looking at round about June, July, August for that really to kick in so that very few people are dying, and then herd immunity, which is likely to happen towards the end of the year in terms of vaccine uptake and so on. So I think those are the general things that will lead to schools being safe. We're not vaccinating children at the moment for reasons already discussed. It's not licensed, we've not tried them, and children in general have lower risks, particularly in primary school, of catching the infection in the first place. So it's probably going to be a case of when the teachers have their turn, they will get vaccinated, and therefore won't be going off sick. And that will be within the general background of less and less people having the infection in the community through herd immunity, and less people being admitted to hospital and putting strain on the NHS. So it'll be interesting to see what happens on March the 8th, which is the putated opening day for schools. So at the moment, as to whether as to what actually happens within those schools once they reopen, because of course, yeah, we are damaging our schools, our children's education. We're setting them back a long way, and we're and there are lots of frazzled parents who are trying to homeschool their children, and of course there are lots of children whose parents don't have the wherewithal to homeschool them as well, and causing particularly serious harm. So it is a really difficult conundrum.
Hello, my name is Tony Herford. I'd like to ask about the efficacy of the vaccine against transmission of COVID. Can an inoculated person still become infected and not display any symptoms? And to follow on from that, would such a person be a vector and able to transmit unknowingly COVID to other people?
So once you've had the vaccine, you can still catch the infection. So the best data we've got are from the Oxford AstraZeneca study, where they actually asked people to take swabs for infection once a week all the way through the study. We didn't get any such data from Moderna or Pfizer. And what that showed was that people could still get asymptomatic infection. So overall, the rate of infection went down by about 55% off the top of my head. And the remainder who did get infected were largely asymptomatic. In fact, that just brings me to a more general point I want to make, is that how the vaccines work in terms of morbidity and mortality. So all the three currently licensed vaccines stop you dying. They all stop you going into hospital. The Moderna and Pfizer vaccine are slightly better at stopping you getting mild symptoms. On the other hand, so some people getting the Oxford AstraZeneca vaccine may get a mild COVID infection, but it is mild, just like a mild sniffle cold. And the issue of whether they actually prevent you getting infection is an interesting point in any case. So we don't know whether that happens with Pfizer or AstraZeneca, but it Pfizer or Moderna, but it probably does. With the Oxford AstraZeneca, we know that it reduces your chance of catching the infection by about 50% or more if it does that, then clearly you can't spread the infection if you're not catching the infection. And so that feeds into the possibility that we'll get herd immunity by enough people in the population being vaccinated. And if they can't catch the infection, they can't spread the infection to some degree. But in saying that, as I say, it's only to some degree. So, roughly 45% of people who have been vaccinated can still catch the infection and carrying it mostly asymptomatically or mildly, and therefore presumably may still transmit the infection. So there will be still some transmission going on in people who have been vaccinated, albeit at a much lower rate than people who have not been vaccinated. No, vaccination isn't the be-all and end-all. It's just one tool. Good hygiene, hands, face, space is going to help prevent the spread of this infection as much as anything, until such time as we've got the majority of people in this country and the majority of people in the world vaccinated.
Hi Mary, this is Dave. Should we be worried that the government isn't planning to follow the Pfizer vaccine manufacturer's recommendations regarding the second vaccination? I.e., the recommended second dose should be 3 weeks after the first, but the government has moved this to 12 weeks.
There are two issues. There's the first, the rollout in terms of one dose rather than two. Perhaps I can talk about that as well. And the Joint Committee on Vaccine and Immunology and the MHRA decided to license the vaccines currently available for one dose followed by a second dose 3 months, even though the original clinical trials had one dose followed by the second dose after 3 to 4 weeks. And that was a pragmatic decision, although it's backed up by some science. So the science bit is that in the Oxford AstraZeneca vaccine, in fact, quite a significant proportion of the people receiving that vaccine did receive the second dose up to 12 weeks after the first dose. So they actually have some data on a delayed dose. And what that data indicates is that the people who received the Oxford AstraZeneca vaccine after 12 weeks actually had a better response than people who received it after the planned 4 weeks, 3 to 4 weeks. So actually there is scientific evidence that delaying the vaccine, particularly for the Oxford AstraZeneca vaccine, actually improves people's response to the vaccine. And so it's probably inconceivable that you would not see the same effect with the Moderna and Pfizer mRNA vaccines, because essentially they're all pretty well doing the same thing, which is producing spike protein from mRNA within the cell. So in fact, there is a little bit of data from the Moderna vaccine that a delayed dose works as well, if not better, but none from Pfizer BioNTech. But from a pragmatic point of view, it makes absolutely sense, because what we've been able to do is vaccinate twice as many people in the same time period by giving one dose rather than two. And just giving some figures, if you have, say, 2,000 people and you vaccinate 1,000 with 2 doses, then you've left 1,000 people with no vaccination, and therefore some of those are going to die from coronavirus. Quite a significant proportion are going to die from COVID. Whereas if you give 2,000 people a single dose, even if your vaccine efficacy is slightly low, maybe say 10%, but I doubt if it will be that. Actually, I think the second dose, delayed second dose, is probably going to be just as effective. But let's say it's 10% less effective, you're still going to save far more lives with that second strategy. So a pragmatic public health decision has been made to do it that way, and I must say I thoroughly endorse it. And I was furious with the BMA when they came out last week criticizing that approach. And in fact, I sent an email to them saying that I'm going to resign from the BMA because of that, because they didn't ask the BMA members whether they wanted them to come up with that policy decision or not. Because the majority of my colleagues doctors, nurses, other healthcare workers are largely in favour of the government's approach of a single dose.
Having COVID gives you some immunity, and you're suggesting up to 6 months. Does the immunity from just getting it naturally, is that higher than having a vaccine? And then they also were asking, if you've had COVID-19 recently, when should you have your vaccine? Is it okay to have it so close to being infected, or should you leave it a few months?
The immunity you get from natural infection seems to be about the same order of protection that you get from vaccination. So in terms of antibody levels and so on. So the expectation is that natural infection and vaccination induced immunity will be similar. But in both cases, we haven't got any data beyond 6 months. So the current recommendation is that if you've had confirmed COVID dated, if nothing else, immunity, and give you even stronger immunity and longer immunity. If someone has recently had COVID-19, you're asked to wait 4 weeks before you have the vaccination, and that's from the start of your symptoms or from when you became PCR positive on a test. The reason for that, I think, is twofold. The first is that you don't want people turning up to the vaccination centre still carrying the virus and potentially infecting people, but also they want to wait for people to feel a little better in terms of symptoms. So wait 4 weeks and then you can have the vaccine. And the vaccine is a good thing to have because it'll boost your immunity over and above the immunity that the infection gave you.
Hello, this is Sue. If someone has had or still has long COVID, should they get the vaccine?
We don't have any data on the effects of the vaccine on people with long COVID because when the study was done, it was early in the epidemic, but the recommendation at the moment is that everybody who has had COVID infection should have a vaccination as a booster to their immunity. And at the moment, there is no reason to believe that it will make your long COVID any worse or make it last any longer.
Hello, this is Lizzie. What is the NHS doing to ensure additional vaccine doses don't go to waste?
Well, I work in a vaccination centre. I actually only started working last week, but I do work in a vaccination centre now. And I can tell you that no doses are thrown away. It depends on where you are. So in the centre that I work in, we are vaccinating mainly healthcare workers. And so we have a walk-in service. So at the end of the day, we will give doses to people walking in up until when a bottle is finished. We're giving the Pfizer vaccine, which is 6 doses per bottle. So if there are only 3 people outside, we need to open up a new bottle. We tell the 3 people to come back in the following morning. So we don't open a new bottle unless we can be absolutely clear that we can give all 6. What other people are doing is having an emergency call list. And so ringing people up who are eligible for the vaccine and saying, look, we've got some doses left, please come now and we'll vaccinate you immediately. So some people have made themselves, available at a, 15, 30 minute notice and are driving in or working their way into the vaccination centre to receive it. But I can absolutely guarantee you that every vaccination centre I know does not throw any dose away at all.
Are there any significant differences for patients on which COVID vaccine they get?
All the currently available vaccines are highly efficacious. They all prevent death and hospitalization, severe illness. So if you're offered a vaccine, take whatever is offered. There are only small differences between the two in terms of whether people should or should not take them. The major one being a history of anaphylaxis. So people who have had anaphylaxis, particularly to a previous vaccine or vaccine component, should not take the Pfizer vaccine. They should take the Oxford AstraZeneca vaccine. But other than that, both are incredibly good vaccines. I don't talk about the Moderna vaccine yet because we don't actually have them. Although it's licensed, it's not available in this country yet. It won't be available for another month or two. But the same will apply to that and indeed some of the other neo vaccines as they come online.
Hello, this is Angela. Does 50% effective mean only 50% of vaccinated people are protected, or that for all those people vaccinated, the infection will only be 50% as bad?
I would first of all say that a 50% response rate to the vaccine is pretty low, because the majority of vaccine responses have been much higher than that, even up to 95%. But I do acknowledge that the South African strain, particularly when the vaccine was tested in South Africa, may give a response rate as low as 50%. But 50% effectiveness means that there is an overall reduction in the proportion of people displaying any symptoms. So, for instance, if you have 1 in 100 of the population showing symptoms, if they're unvaccinated, only 1 in 200 of the population will get symptoms, and even then they only get mild symptoms. So these vaccines, however, I've got to stress, are 100% effective at preventing people going into hospital, and 100% effective at preventing people dying.
Does giving out the vaccine encourage the virus to mutate much more, resulting in vaccination being less useful?
The biggest reason why the virus mutates is a large number of people who are infected, and therefore a large amount of virus reproducing all the time, which as a result leads to spontaneous mutations. So the best way of stopping mutation is to reduce the number of people who are infected. And the best way of doing that is through vaccination and these hands, face, space sorts of hygiene that we are so used to. It is possible that the the virus may mutate such that it becomes less susceptible to the vaccine. But as I think I've said elsewhere, the companies producing vaccines are able to manipulate the vaccines very quickly so that we can cover these mutations and provide an effective vaccine very quickly.
Next, 2 questions about the science of the virus. There seems to be a certain intelligence surrounding the behaviour of this virus to enable it to optimise its own efficacy. So my question is, by what mechanism does the virus mutate? Is there some innate knowledge in the beast? And then, it has been said that the vaccines permanently alter the body's DNA. Is this true, and should we be concerned?
When someone is infected with coronavirus, millions of copies of the virus are made, and millions of copies of the viral RNA are made. Sometimes mistakes happen during part of this reproduction, and these mistakes are called mutations. In most cases, mutations are of no significance, but on very odd occasions, the mutation leads to an advantage to that particular variant of the virus. For instance, enabling that particular virus to spread more easily. This has been the case, for instance, with the Brazilian, South African and Kent strains, but these have arisen spontaneously by chance because of the millions of reproduction. As far as DNA and RNA vaccines are concerned, they do not interact with cellular DNA inside our body, and there is no possibility of mutations of our own DNA happening, so there is no need to be concerned. And in fact, the DNA and RNA that is injected into our body as part of these vaccines is broken down very rapidly, again emphasizing the point that these sorts of untoward events just cannot and do not happen.
What are some of the common vaccine reactions?
Yeah, most people don't get much in the way of side effect. When I had it, I had very, very minor discomfort in my arm for a couple of days. I've had one colleague who had a slightly more intense reaction where her upper arm swelled a bit and she was feverish and felt a bit fluey, but that all settled down with some paracetamol, and I think she took the day off work. So the vast majority of people have very minor reactions, no more than you get with an annual flu vaccine.
And that links to another question. A few people seem to have had the flu and then a COVID vaccination close together, and they seem to feel a bit unwell. Is that naturally because they're a bit older, their body's having to adjust to two different things?
So the government recommendation is that the flu vaccine and the COVID vaccine should be separated by at least a week, and they should not be given together. And that's for the reason that both can give you side effects, make you feel unwell in terms of feeling fluey, sore arm, and so on. So that will be twofold if you get a reaction to both vaccines. In fact, in the United States, the recommendation is to separate the two by 2 weeks. So if you do happen to get the two vaccines closer together than a week, it's not a big problem. You'll still respond to both vaccines, but there is a risk that you'll feel a little bit more unwell because you've got the side effects of two vaccinations.
Some people are reporting that they have no symptoms from the Pfizer vaccine, but the AstraZeneca, when they've been comparing, chatting to each other, is making them feel more poorly afterwards. Do you know, more aches and pains and flu-like symptoms and feeling quite unwell from the AstraZeneca? Have you got any information on that?
I have no information which compares the rate of side effects between the two vaccines. I think in the original clinical trials, the rate of side effects for the two vaccines was the same. So this is just maybe a case of you happen to know somebody who with symptoms who are more likely to say that than people who don't have symptoms.
Do the vaccines include any ingredients that are causing controversy on social media?
So we've got the two mRNA vaccines, which essentially have RNA and lipid, and they have a polyethylene glycol preservative, and that's the one that seems to be causing the anaphylaxis, although there are one or two other chemicals in there. So people with polyethylene glycol allergy shouldn't get the Pfizer vaccine. The AstraZeneca vaccine is a adenovirus vector, but there are nothing in it otherwise that might cause people concern. This might lead on to some people's concern about how they were produced. So the mRNA is entirely manufactured, but there is this story going around about fetal tissues and the Oxford AstraZeneca vaccine. First of all, there's no fetal tissue actually in the vaccine. It is a purified adenovirus, non-replicating adenovirus. However, it was grown on a tissue culture. The tissue culture derived from a cell line that was taken from a fetus that was aborted about 60 years ago, and then has been grown in perpetuity ever since then. However, the cells from that tissue culture are not present in the vaccine.
And meat, there's no meat in any of the vaccines either. That's one of the other scare stories.
There is no pork or meat. The various Muslim organizations, I think the Muslim Council of Great Britain, certainly some mosques have said that it is halal. In other words, that there is no meat involved, no pork involved particularly, but there isn't in any of the vaccines. There is no meat at all.
Okay, so this is
nor is there any eggs. Sorry.
Oh, all right. So that was interesting because my next one was going to be the intolerance to eggs. So none of these ones have an egg derivative in them at all.
The vaccines do not use egg. The flu vaccine is grown on egg cultures, but the current COVID vaccines do not. So there's no egg involved. If you've got an egg allergy, you don't need to be concerned.
Oh, very good.
Hello, this is Jean. I had a question about the immunisation programme. The UK appears to be doing a fantastic job rolling out the immunisation programme. We've immunised more people than all of Europe combined. Why are we doing so well, or is it that others are just doing a poor job?
One thing that the current government has got right in this pandemic, and I've been hypercritical of them for not getting it right in other areas such as lockdown and PPE and track and trace, where I feel the government have underperformed. But they've actually overperformed in terms of vaccination. And the Vaccine Task Force have done a brilliant job. It's Kate Bingham, I think is the name of the lady who runs it. And she went out to all the manufacturers with the help of experts. She identified those manufacturers who were most likely to produce the vaccine at scale. They identified the manufacturers who were most likely to produce an effective vaccine, and then put a large amount of money both in the development of the vaccines. And I'll just a shout out for the UK that both the Novavax vaccine and the Oxford AstraZeneca vaccine both came out from clinical trials in the UK first before anybody else. And so the government invested in these studies and took a punt and said, look, we're willing to give you money up front. That then gave the companies the financial freedom to then scale up to be ready to produce the vaccines as soon as the phase 3 trial results came out. And the Vaccination Task Force have done a fantastic job, as opposed to, say, the EU. And again, if you listen to the 1st of February How to Vaccinate the World programme, they discuss this whole issue in detail. And the problem with the EU response is that it's been large and slow and bureaucratic, and has not taken a punt in terms of investing in R&D so much, and in not investing in drug companies that they think that they can deliver. And so they've found themselves well behind the UK and America. America's been the other place where vaccination development has gone at a great speed. And so that we've had then the unedifying sight of people arguing over not exporting vaccine to the UK as tit for tat for not receiving the AstraZeneca vaccine and all that sort of nonsense. So all that sort of vaccine nationalism.
Hello, this is Lydia. I'm 17 years old. Please could you tell me when the phase 1, that is the 9 priority COVID-19 vaccination groups down to all those aged 50 and over will be completed, and then when the rest of the population will have been vaccinated by?
The 9 priority groups, it's hoped that they would be vaccinated by late spring. And we're talking about the entire population being offered a vaccine by the autumn.
Hi, my name's Karen. I wanted to ask, Group 6 in the vaccine rollout is described as 16 to 64-year-olds with serious underlying health conditions. Is this the same as the people who would usually get the free flu jab each year, or are the underlying health conditions only those specific to COVID risk?
As far as I'm aware, the list of health conditions is pretty much the same for both flu vaccine and COVID vaccine. I did have a quick scan earlier and I didn't spot any major differences between the two.
How can this vaccine protect extremely clinically vulnerable, i.e. those who have limited lung capacity? And is it likely the vaccine will not prevent death from those who are extremely clinically vulnerable?
The answer is that I don't know, in as much as in the clinical trials, although there were some comorbidities, I don't think those comorbidities amounted to extremely clinically vulnerable. And I think this answer would be the same for pretty well any vaccine. We think that vaccination will offer some protection, but it is likely that the protection will not be as great as it would be for people who don't have extreme vulnerabilities. And that's particularly so for people with immune problems, because we've already seen that with the Janssen vaccine. So the Janssen vaccine in South Africa was about 10% less effective in people who are HIV positive. So I think that people who are extremely clinically vulnerable will still continue to need to isolate hands, face, space quite assiduously, even when vaccination becomes more widely available and when they have received 2 doses, because there may be a reduction in efficacy.
Hello, my name is Teresa. My sister had celiac and she understands that this could mean her spleen is compromised, so may affect her autoimmune system. Does this mean that she cannot have either of the current approved vaccines on offer?
No, quite the opposite. She would be recommended to have the vaccine as soon as possible. And in fact, in the definition of extremely clinically vulnerable and clinically vulnerable, there is a category for people who have either had their spleens removed or otherwise their spleens are not working. And they have been put in a priority group. So extremely clinically vulnerable is group 4, I think. Clinically vulnerable, I think, are in group 6. And so the recommendation is that people with splenic problems should have the vaccination as a priority to give them immunity, as much immunity as possible, as early as possible.
Hello, this is Sarah. I would like to ask 2 questions. Firstly, is it still possible to pass on the virus once you've been vaccinated? And secondly, my mum Alison had her first Pfizer vaccine nearly 2 weeks ago. She's delighted to have had it and is looking forward to meeting up again indoors with us soon. So when will it be safe for her to meet with us again?
So there are several aspects to this question. So your elderly relative will be fully covered in terms of vaccination and reduction in mortality and hospitalization about 2 weeks after the second dose. That's what the data suggests. Although in fact, as I've already suggested, the reality is that they're more or less covered about 2 weeks after the first dose, and that so the small improvement after the second dose is relatively small. So they won't die if they catch it, and they won't go to hospital if they catch it, but you visiting them could still take the infection to them, and you can still infect them, and they may get mild infection or asymptomatic infection, and then they may infect other people who visit them. Of course, if you are in a group that has not already been vaccinated, then you should be still trying to prevent the spread of infection by hands, face, space, sticking to bubbles, sticking to lockdown, sticking to all the advice that has been given from a public health point of view about spread of infection, because vaccination is just one part of the fight against this infection. It is not the only one. You can't throw everything else out the window just because somebody's vaccinated.
Our next question is, I believe there are 2 COVID tests, one to tell you if you currently have COVID and therefore are infectious, and one to tell you if you have previously had it. What are the names of the 2 types of tests, please?
So you're right, there are 2 types of tests. There is the antibody test, which is a blood test, and it's usually done as a finger prick sample put on a test strip, again, rather like a pregnancy test. And that tells you if you've had the infection in the past. The other type of test is one where we look to see if someone is currently infected. And again, there are 2 types of that test. There's the lateral flow test, which gives you a result in 30 minutes or less, and can be done on a nose swab or a throat swab. And then there's the test that's done in the testing centres called PCR and other similar tests, which is more accurate, and that takes about 48 hours, sometimes a little bit longer for the result to come back. And the use of these tests is different. So we have the test to tell us whether you're currently infected, and that tells us whether you need to isolate and give you some idea as to what course your illness may take. More interestingly, the antibody test has up until now been used just to tell us how many people in the community have been infected. And for instance, we now know that about 12% of the population of UK have had the infection in the past. But with a positive antibody test, it might in the future give us more information, for instance, whether we only need to give 1 vaccine dose rather than 2 vaccine doses, because we may decide that once someone has been infected in the past, they only need a booster dose following that. I would also add a rider, though, that beware of tests that you buy on the internet, because the antibody tests that you can buy are sometimes not very good, with a high rate of false positive and false negative results.
Will the supply be enough to guarantee receiving a second dose within that period? And then some people are asking your view on if there isn't enough supply of the one you had originally, have the second dose from a different source.
So there have been some concerns in the last week with the spat between the EU and Britain and AstraZeneca about vaccine supplies, as to whether the EU will allow enough Pfizer vaccine to come to the UK, and whether they will try and divert some of the UK production of the AstraZeneca vaccine to go out to the EU. But the information we are receiving from the government is neither of those will affect our vaccine supplies, and all vaccine supplies are expected to be as ordered. However, should that not be the case, and I'm still reasonably confident that everybody will get the second dose of the vaccine that they need or received. The fact is that all the licensed vaccines at the moment, and indeed the new vaccine, most of the new vaccines coming online, work on the same principle. They work on the principle of antibodies and cell-mediated immunity directed at the spike protein. So it's just that they all stimulate your immunity against a spike protein by a slightly different mechanism, but that's what they do. So in theory, you can mix and match the vaccines without any problem at all. So you could have the Pfizer vaccine as a first dose and the AstraZeneca vaccine as a second dose. And just as an aside, AstraZeneca always thought that that was going to be the case. In other words, the AstraZeneca vaccine is packaged inside a incomplete adenovirus. When you inject that adenovirus, not only do you produce antibodies against spike protein, you get antibodies against adenovirus. In other words, the AstraZeneca vaccine may well not work anymore in people who have already had 2 injections. So the 3rd or 4th injection may not work. It's quite likely that it won't work because you've got antibodies that are stopping the incomplete virus getting into the cell. So it was always envisaged with the AstraZeneca vaccine that booster doses after the first 2, maybe 3 or 4, would be of a different type of vaccine, such as the Pfizer vaccine. Although there are other ways of doing that. So AstraZeneca, I think it's AstraZeneca, certainly Oxford, have teamed up with the Sputnik vaccine in Russia, which is also an adenovirus vaccine, but they use a different adenovirus, and so in fact they use 2 different adenoviruses for the different doses, and so there is discussion about swapping the adenoviruses around for subsequent doses, for the Sputnik virus and the Oxford AstraZeneca virus. But the bottom line is, I am confident that if it did come to using a different vaccine for your second or subsequent dose, it would work fine.
Then there's a question about if the whole world is producing, or the manufacturers are all producing COVID vaccines, surely they have to be producing all the other vaccines that we would have naturally. So again, do you believe the capacity can just expand as the demand increases and then shrink as it dwindles?
As far as I'm aware, all the vaccination capacity that's being used is new and has not impinged on the production of all the other vaccines currently available or previously available. So as far as I'm aware, COVID vaccine production will not alter other vaccine production in any way.
After 12 weeks, when all those who have been vaccinated once need their second jab, will this effectively mean a 3-month pause to new vaccine patients coming in?
So when people come up for their second jab at 3 months, so I was vaccinated on December the 25th, so I will be so January, February, so I will be due mine on the 25th of March, and so people vaccinated before me and after me will all need to receive their second dose. That therefore will mean a reduction in the ability to offer people the first vaccine. However, I think the thing to point out is that when we first started vaccination, we were only vaccinating in the tens of thousands initially, and then now it's gone up to the hundreds of thousands. So actually, vaccination capacity is just continuing to expand. So I don't think the impact of people receiving the second vaccine is necessarily going to have as big an impact on people getting their first vaccine as people might worry, because other things are going to happen as well. So for instance, by March, we may well have the Janssen and the Novavax vaccines licensed, possibly even available for use as well. So that there may be a wider range of vaccines that can be used as well. So better vaccine supplies to help vaccinate more people.
So increasing the supply of vaccines would mean that we'd need an increase in the task force to help to administer them, probably, because they're building the big centres where we can all go, and local centres. So then, and there's appeals for like the lady I know who's a vaccinator, or she helps in the car park and does the admin or something. But there's a whole team of them. Some of them are used and some of them are not being used. So there probably is going to be a time where you probably would need to volunteer to be a helper at these things. We're not at capacity of that yet at all, are we?
The rate limiting rate limiting step at the moment is availability of vaccine. We seem to have more than enough capacity to vaccinate people. So we're vaccinating people as fast as the vaccine becomes available. So, for instance, my vaccinating centre is not open today because I presume we've met our current targets and will open later on, and so that vaccine has been given to other vaccination centres where targets have not been met, to make sure that there is an equitable distribution of vaccine throughout the regions, throughout the country. So. Again, looking at my own vaccination centre, I would have thought that there is more than enough physical capacity to increase the throughput of people coming for vaccination. And that's even using the Pfizer vaccine, which is a difficult one to deal with because of the -70 storage and all that. As the newer vaccines come along, which can be stored in a refrigerator and or even stored at room temperature, then vaccination points can be extended even further. So general practices, pharmacies and the like will also be able to offer vaccination. So I think that the infrastructure to vaccinate will cope with increased numbers of vaccine and therefore increased numbers of people wanting the vaccine.
My question is, why haven't GPs and pharmacies been given the vaccine to distribute, which they already do for flu, instead of centralised vaccine centres, which might involve long travel?
So at the moment, we only have 2 vaccines that are being distributed in the UK, the Pfizer-BioNTech vaccine and the AstraZeneca-Oxford vaccine. In the case of Pfizer, it's stored at -70 degrees and comes in batches of 975 and has to be used within 5 days, the entire batch. Therefore, that can only be used in large centres with all the facilities to store it and use all 975 doses within 5 days. The Oxford AstraZeneca vaccine can be stored at refrigerator temperature for many months, and so is more suitable for use in smaller centres, and that is generally happening. I do anticipate, particularly as more and more vaccines become available, that small pharmacies and general practices will be used. However, all of these vaccines at the moment come in multi-dose vials. So the AstraZeneca vaccine comes in multi-dose vials of 11. So you've got to give 11 people the vaccination within a matter of a couple of hours. Otherwise, it's wasted. For the Pfizer vaccine, it's 6 doses per vial. So again, you've got to be absolutely sure that you've got the wherewithal to vaccinate 11 or 6 in either case within a matter of a couple of hours, so as not to waste the vaccine.
Does UV light kill coronavirus, and is it worth investing in a UV light?
Ultraviolet does kill COVID, but it's the only UVC form of ultraviolet that kills it. That's the more extreme damaging form of ultraviolet, and it's difficult to see how ultraviolet machinery in a family home can make any difference. I think there are some air filters that use UVC, but I think the figures are that the virus has got to be exposed to UVC for something like 25 minutes to kill it. So if you've got some sort of air conditioning or air filtering system which uses UVC, it might make a bit of a difference. But having a sort of portable UVC machine that you shine on surfaces is probably of no value at all, and you're just as well wiping it down with soapy water or dilute bleach.
Good afternoon. My name is Gillian Conway. My husband and I are in our late 60s and we live in Welham Green. We are both completely and utterly in favour of the COVID vaccine and are fortunate enough to have been vaccinated ourselves recently. Our question is, how important do you feel an adequate supply of vitamin D is in boosting our immune systems and therefore our defence against COVID?
So vitamin D deficiency has been seen in a great many people, not only with COVID, but in people with a great many other illnesses. And there does seem to be a link between vitamin D deficiency and illness. However, there is no proof that giving vitamin D supplements makes any difference to people's illness or people becoming ill. So it's a strange area where, on the one hand, it would seem obvious that vitamin D supplements are required and should be given, but actually there's not a lot of evidence that it does make any difference. In saying that, the government have made vitamin D available free of charge to the clinically extremely vulnerable. So if anybody wants to apply for a free vitamin D supply, they can do so. And most of us, particularly those of us who don't go outside and get vitamin D from sunlight on our skin, there's certainly no harm in taking vitamin D supplements in the winter months when you're indoors. And this particularly applies to people from the BAME community who seem to be particularly prone to vitamin D deficiency, and particularly people who cover up a great deal as part of their cultural and religious practices.
How much is the immunisation programme costing the UK? Not just the purchase of the vaccine, but the logistics as well.
I did see a figure somewhere. I think it's predicted to be somewhere just short of 18 billion for the programme, of which the vaccines themselves cost just a little short of 3 billion, and the rest is in infrastructure. That's how much it's predicted to cost once the entire population is vaccinated.
What percentage of the population needs to be vaccinated before we can expect the R rate to drop significantly?
Reduction in R rate depends on many things. The current way of reducing the R rate, that is the reproduction rate, the rate at which the infection spreads through the population, the current way of reducing that is hands, face, space, and lockdown. And as a result of the current lockdown, here we are in the beginning of February, the R rate has just fallen below 1, meaning that there are fewer cases being infected than there are actual infections at the moment. So each person infected is infecting on average less than one other person. Vaccination will feed into that eventually, but it's going to be many weeks, if not months, before vaccination has an impact on R rate. Although I did see an interview with Susan Hopkins from Public Health England saying that she thought that the effect of vaccination on spread will start to be seen in a couple of weeks' time, in other words, mid to late February. And because vaccination alters spread of infection, by dint of that, the reproduction rate will be reduced. The fact that we're vaccinating older people first means that there'll be less of an impact on reduction in spread in the community, because they're the people who are less likely to go out anyway. But as part of the government strategy, we're also vaccinating health and social care workers, which are younger people as well. And we're up to 9 million people vaccinated at the beginning of February. By the time of the Saturday programme, it'll be about 12 million. And so a sizable chunk of the population have been vaccinated, at least with a single dose.
This is Patricia. There's been a lot of claims made, especially on social media, about the effect of the vaccine on fertility. Could you please tell me, how have they ensured that this won't be a problem?
Yeah, it's very disappointing that people have put out the disinformation or fake news, if you like, that vaccination causes infertility. I can say categorically that vaccination does not affect your fertility in any way. There is absolutely no way that it should. There is absolutely no way that it does. And this was information that was put out either maliciously or mistakenly. I'm not absolutely clear why, but it has fed into people's fears about taking a vaccine, particularly in younger people in their fertile years, when they're worried about having children, and therefore leaving them to say, well, I'd much rather have the COVID-19 infection when I'm not going to die from it, although of course you have a significant risk of getting long COVID, than put my fertility at risk. But I would like to state here and now categorically, the vaccination does not affect fertility, but COVID-19 itself does affect fertility. And there is now accumulating evidence that COVID-19 infection in men reduces their sperm count and reduces their mobility and reduces markers of inflammation in the semen. So it is quite likely that COVID-19 is going to reduce men's fertility, at least in the short term. I suspect that after months it will recover, but it was shown in one study that men's fertility went down for at least 2 months after getting COVID-19 infection. If there's any story to be had, it is that COVID-19 is quite likely to reduce men's fertility, at least in the short term.
Hello, this is Jean. I had a few questions about so-called anti-vaxxers. So anti-vaxxers are heard easily through social media, so why aren't professional bodies employing the same methods?
I have to agree with you. I think that the government and the NHS and the Department of Health have been very slow in their education and their interventions. They are paying internet influencers, I understand, to promote positive messages, and they are working with the social media companies, Facebook, TikTok and so on, about taking these malicious or at least misinformed messages about vaccination offline as soon as possible. But that is something where not only we in the UK, but people in general in the world have been very slow at dealing with the problem, is counteracting all this misinformation and disinformation that there is there.
Is an anti-vaxxer always an anti-vaxxer?
So there are a minority of people, I would put them at no more than about 5% of the general population, who are anti-vaxxers. And these people usually have a long history of being anti-medicine, anti-technology, or at least anti-technology in the way that we know and use it. And it is often said that they are a lost cause, and it may well be the case. So we have to concentrate on the so-called vaccine hesitant, which is about another 25 to 30% of the population, who are people who are seeing all this misinformation and disinformation on social media and are frightened of coming forward. And we've got to try and persuade them somehow into taking the vaccination, persuading them that not only is it good for them, it's good for their family, and it's good for the general population. And so those are a group that are susceptible to change if we try hard enough.
How do you feel about the fallacy of the MMR and autism myth?
I'll have to let you all into a little secret and don't tell anybody, but I used to work with Andrew Wakefield, the propagator of the MMR and autism myth. When I worked with him, he was a bright young research registrar, and we did some great research together, valid research. So it was after we lost contact that he actually went down this rather bizarre track of putting out that multiple vaccinations given together led to autism. That has been roundly and strongly debunked by a mass of information showing that the MMR vaccine does not cause autism. It is safe, but it is in many ways a prequel to what we're seeing now with the anti-vax group. If someone says something loudly and frequently and puts an air of authority about it, even if they're wrong, many people who don't have the scientific wherewithal to say that's wrong may believe them. That's what happened with Andrew Wakefield, and that's what's happening with the anti-vax message now, which is a real shame. Yeah, measles vaccine has come and gone, and it's a particular problem with measles, because we talked about herd immunity before. Measles is a vaccine that needs to be given to 95% of the population before you get herd immunity. So it's extremely sensitive to a reduction in vaccine rate, which then leads to epidemics of measles in the general population. I really hope that herd immunity will be achieved as low as 60 or 80% with the COVID vaccine, but we really don't know at the moment. It varies from infection to infection.
What can be done to get those who don't trust the speed in which the vaccine was found? They believe corners were cut.
So vaccine uptake has been extremely good in the elderly, but the two parts of the population where we anticipate problems are younger people, because of misinformation and disinformation spreading on the internet, such as the fertility problem, but also in BAME communities. And again, I would like to give a plug for a program on Radio 4, which was 11 o'clock on Monday morning, called My Name Is, and it was a group of vaccine ambassadors in Bradford trying to deal with the BAME community and dealing with their concerns and addressing those concerns, because there is a lot of suspicion amongst some BAME groups in terms of what the intentions of the government are, what they have a mistrust of authority. They quite rightly point out to past injustices against BAME people and say, why would this be any different? And then tied into that is the disinformation that's going out about fertility, about vaccines being ways of Bill Gates injecting nanobots into your body to control you, all that sort of nonsense. But people believe it, and you say, some people say, why believe it? But you know, people do believe it if they're not scientifically particularly literate, which, you know, dare I say it, is probably a large proportion of the population, and so people do buy into these conspiracy theories. So I think that only a minority of people are dead against the vaccine, but a significant minority are what we call vaccine hesitant and do have suspicions and concerns and worries about the vaccine, and that's going to be the problem once we start to get into the offering the vaccine to those groups which are particularly represented by them. I just give you a figure. In my own hospital, we've vaccinated over 90% of all white members of the staff, and we've only vaccinated about 55% of BAME members of staff. All have had equal access. It's just that the BAME staff have not come forward as willingly. And part and parcel of that is also, I don't think the government have been, and the NHS have been proactive enough in intervening and in getting the message out about vaccination and dispelling these myths.
Hi, my name's Neil. I'd love to know, what are the main challenges you and your NHS colleagues are facing with rolling out this heroic programme?
The biggest challenge is really capacity. There were times during the current lockdown where some intensive cares were absolutely full and we're having to send people away several hundred miles. In fact, that's the biggest problem. In terms of vaccination, it's just all about logistics. It's actually a very jolly place, a vaccination centre. If you're somebody working there, I really enjoy it. Sit around chatting and people come in and are very happy to have the vaccine and then go off again very pleased, and it's all a very warm, cosy feeling place.
If the country continues to have open borders, will we just keep reinfecting ourselves?
That is a difficult issue, because we can't have closed borders forever. We've got to trade, we've got to travel, and so the solution to that is making sure that the coronavirus pandemic is brought to a halt, and that means making sure that vaccine is widely available all over the world. But in the short term, there are going to be problems. So I've just heard today that there's been an upswing in South African variant in the UK, which is causing some slight concern. And they've today, Monday, they're increasing testing in various parts of the UK for the South African variant as a result of that. But all that closing borders does is delay spread. It doesn't stop spread. The vaccines have got to be distributed more widely to reduce the infection. But if there are new variants, we've got to be nimble in altering the composition of the vaccine so that they are effective against any new variants that arise.
Hello, this is Ian. What are your thoughts on sharing the vaccine with the world?
Again, I give a plug for the How to Vaccinate the World programme at 11:30 on Monday, the 1st of February, because it covers that topic in great detail. I think there are several issues. The first is production and distribution. So how do you get that to the rest of the world? And the second one is need. So interestingly enough, two of the countries that have invested most in vaccination are two of the countries with the worst problem. So the UK and America are two of the top 4 worst affected countries in the world in terms of COVID and deaths. And therefore, there's an argument that those are the places where the vaccine should be used at scale first, because we've got such a terrible problem. And therefore, you should distribute the vaccine not uniformly, but to those countries for whom COVID is more of a problem at first, and then to countries with less of a problem. There is an international program called COVAX, which seeks to distribute vaccine all over the world. And as more and more vaccines come online, as more and more distribution, as more and more manufacturing centres are built, then the capacity will go up. But I think the even most optimistic answer to that question is that it'll probably be about 2 years before we've vaccinated the world.
Hi, my name's Neil. Our 3.5-year-old daughter now plays at being a doctor who's helping people. How does it feel to know you and your NHS colleagues are role models for boys and girls alongside pop stars, sports stars and social media influencers?
It's really nice to hear that, and I myself am full of admiration for my colleagues on intensive care and working on the wards, which is an area that I no longer do since I retired a couple of years ago. I think the important thing that comes out of this that is if people see positively a career in health and social care, then that can be only good, because I have had a very fulfilling career over the last 45 years in medicine and would highly recommend it to anyone who wants to go into that sort of new career.
Hello, this is Mary. I have 3 questions, please. Does going into hospital with or without underlying health conditions have a high risk of contracting COVID-19?
Hospitals take infection with COVID very seriously, particularly the fact that patients in the first wave did catch COVID or coronavirus SARS-CoV within the first wave, and now they've put in a great deal of measures to try and prevent that happening in the future and now. So, for instance, when people are admitted as an emergency, they are immediately tested with a rapid test for SARS-CoV. And if they are positive, they are managed on a separate ward with other people who are infected. And if they are negative, they are put into separate areas where people are not infected, therefore to prevent them getting infected whilst in hospital. And people are also tested a second time, usually about 3 or 4 days after admission, again, just to make sure that if anyone has coronavirus infection, they're kept completely separate from people who are not infected, and therefore preventing spread of infection within hospitals. And in fact, some hospital groups have gone even further, where particularly if people are being admitted for procedures and routine procedures, they get a coronavirus test a couple of days before they're admitted. And again, if they're admitted to a hospital, they go into an area where everyone else is negative. And in some cases, they even go to a hospital where everyone in that hospital is not infected with coronavirus, because if there are 3 or 4 hospitals in the group, that is possible to do. Therefore, I would encourage people to go to hospital if they need to go to hospital, either that they're seriously ill and need admission to hospital, or if they have been called in for a routine procedure, because every effort has now been made to make sure that people going into hospital do not get infected with coronavirus whilst they are there. And therefore, I would encourage people to go there now, because the risk of catching infection in hospital has been greatly reduced.
What is the survival rate for those going into intensive care? Should the government post figures for people surviving intensive care to demonstrate the successful treatment as a morale booster for NHS staff?
So the survival rate in ITU is approximately 50% at the moment, but you've got to take into account that they are a different population to the people who were in ITU in the first lockdown, and in the first lockdown, the survival rate was about 30% or thereabouts, a little bit, 30 to 40%, I think. They are a different population in as much as a lot of people we're now managing to prevent going into ITU because of giving them treatment on the ward with oxygen, CPAP, and dexamethasone treatments like that. So they're only getting to ITU if they're relatively more sick than they used to be before. It's apples and pears comparing the two lockdown in fact, but the bottom line is that the mortality has reduced overall by about 40% of people getting seriously ill because of the new treatments. People admitted to hospital now have a very much higher chance of surviving than they did in the first wave, because of the benefits of steroids, the benefits of the new monoclonal antibodies, which previously were used in rheumatoid arthritis, but again have been shown to increase survival in people with severe COVID. I think people working in the NHS are entirely clear as to what the success is of looking after people in intensive care, because when people get into intensive care, they are the people who are the ones most at risk of dying, and therefore, by dint of that, have a higher risk of dying, unfortunately. But I think the big message we need to get out there is that treatments are so much better now that overall people with serious illness are dying less. And that's a message that really needs to be taken on board by everybody. But I know that it has been taken on board by people working in the NHS already.
Why can't the vaccine be given in oral form?
So there are 2 vaccines already under investigation which are not injectable. So there's one which is in an oral tablet form, which uses the same technology as the Oxford AstraZeneca and the Janssen vaccine, an adenovirus vector, but it's given by tablet, and that's in phase 1 trials. And then there is a live attenuated vaccine. So that's where they've taken the coronavirus and taken a bit of its RNA out so that it can't harm you, but it still can grow a little bit. So that something, say, similar to the MMR vaccine, for instance, and that can be sprayed up your nose. So we've still got to go through phase 2 and 3 trials of those vaccines. So I expect they'll be available, all being well, towards the end of the year.
Hi, my name's Neil, and I'd love to know, what message would you share with people who are concerned or scared about having the vaccine?
I would say to them that please do not listen to people on social media or to friends or indeed even family who tell you stories and yet they are not experts. The bottom line is that COVID is a killer. It's killed over 100,000 people in this country already. By the end of the year, there are going to be many more people than that dead as a result of COVID-19. And that's not to take into account the people who have been seriously unwell because of acute infection and people still suffering from long COVID or still suffering as an after effect of being seriously ill. Just listen to Michael Rosen, the poet, about his experience of COVID. And I think that if you listen to him and look at what he's got to post and say on YouTube, then I think you may come to a very different conclusion as to whether having COVID is preferable to being vaccinated.
After everyone's had a vaccine, do you still see wearing of masks being compulsory?
I don't know about compulsory, but people will have known that in Southeast Asia, particularly, the wearing of masks is pretty well routine, particularly for anybody with a cough or a cold, and has been for many, many, many years. And I strongly suspect that that's going to be the case in the UK. I don't think it's going to be compulsory unless COVID or coronavirus epidemics continue in this country. And I really don't know when the epidemics in this country are going to stop, because on the one hand we hope that everybody's going to be vaccinated by the autumn, but as the people have pointed out, if you get the Brazilian, South African variants into this country, it could push back that time, because we then will have to create new vaccines against those particular strains, and that may then cut down the time when we're relatively coronavirus free. So I think that hands, face, space is going to be with us certainly for the rest of this year, and could well be beyond, and that really depends on vaccination and variant spreading in the community.
Where do you see the future for vaccines?
So people will have known that at the beginning of the epidemic there was a massive attempt worldwide to produce vaccine, and at one point there were 200 vaccines in development. At the moment we're down to about 50, and so 150 have stopped development for a variety of reasons, either because it was economically not sound, or because there were problems with the vaccines, such as the one in Australia that gave you a false positive HIV antibody. But there are lots of new vaccines still under development, as I say, about 50. And so there'll be lots of variations in the way that they're given. They'll become more convenient. There certainly will be lots of options to choose one or the other according to the circumstances. And one that particularly caught my eye is the Imperial College vaccine. So people may have heard that Imperial College were developing an mRNA vaccine, which has gone through to phase 2, but they've decided not to go to phase 3 because they feel that there are enough mRNA vaccines out there already to provide what the world needs. So what they've decided to do is target their research on the things that people are worried about. In other words, new variants, looking at how their vaccine may be ready to protect us against new, more pathogenic, more transmissible variants of the vaccine. And the Imperial one is particularly interesting because it's an entirely new technology. Again, it's called self-amplifying mRNA. So the Pfizer and Moderna vaccines are just mRNA which are injected. They are copied to produce protein, and then they are broken down by the cell, whereas the Imperial College one amplifies. In other words, you inject it and the RNA reproduces itself inside your cells, so it makes more copies of itself and therefore produces more copies of the spike protein, which in theory gives you a much better immune response for a much smaller dose. So there's lots of really interesting research going on out there, and I'm really proud of my research colleagues who have put a lot of time and effort and thought and skill into making us all safe.
Is COVID-19 here to stay, and will normal living ever return to the way we knew it?
I don't think that we're ever going to get coronavirus eradicated from the world. We are going to reduce it, particularly in the UK, where we expect to have widespread vaccination available, to similar levels to what we see with the yearly flu epidemics. In other words, that we will have to probably make sure we're all immunised and immune on a regular basis, and that may well be yearly vaccines in the same way that we do with flu, to give us a relative degree of normality. But I suspect that there will be some outbreaks on a yearly basis of coronavirus in the UK, but particularly more widely elsewhere in the world, where the vaccination distribution and infrastructure may not be so effective as it has been in the UK.
Right, so I think it's time to say goodbye, as I normally say in my radio show.
Yeah.
Thank you very much for a very informative afternoon, Gary. I have learnt lots, as I hope our listeners have, and that we have achieved your ambition to encourage everybody to get vaccinated and to find out how they can get behind the myths.
And thank you very much, Mary, for inviting me along. I know you've put many, many hours of work into putting this program together. And I really do hope that through this program, we've dispelled myths, we've enabled people to go out and get vaccination with confidence. And again, I would like to just remind the listener that we are dealing with an infection that kills and causes severe long-term disability in some people. So if we've, even in a small number of you, change your mind, I think we've done a good job. So if people want to get factual, up-to-date information, I would first of all avoid a lot of social media stuff coming from sources of unknown quality and unknown veracity. I would encourage people to go to reputable websites and reputable sources such as the BBC, such as the COVID symptom tracker on Zoe. Look that up. That's with Professor Spector. That's a really good source of information. There's a lot out there that tries to confuse us deliberately, and that has only led to a lot of problems in the general population. So just stick to what you know is good.